Good morning. Thank you for inviting me to India here. This is my first time. I came from Egypt and I have a passion here to India. The aim of this presentation actually is just to report the alignment accuracy of PSI based on literature and also on our studies. And I'm going to focus on our studies because actually we have different types of patients from what's reported in the literature. And also we have a different technique for PSI. And that's what I'm going to show here. I'm going to rely on 2 laboratory studies and 1 clinical study. I said we have different types of patients. As you can see here, they come with late presentation. They come with severe, usually varus. We have less inflammatory arthropathy than Caucasian. And also they have different demands. They walk less and they like squatting and sitting on the floor, cross legs. They have different psychology, and also the economy is different. Is 1/3 of our patients, they have a complex primary TKE, and that's based on the Egyptian community register. Therefore, they will require different solutions, for example, like a PSI or a bilateral simultaneous. If you look at conventional JAGs, one of the factors that many surgeons don't know that the cost of this instrumentation exceed $100,000. So for any countries like developing countries in Africa, it would be very difficult for distributors to have different sets of instruments. And also, most of the hospitals, they don't stock either implants or instruments. So this is a huge limitation. And also the currently available PSI from implant companies, they are expensive, the logistics is very difficult, and none of these countries actually, of developing countries, are enjoying the privilege of using a PSI. These are the currently available PSI. This table was published in Surgery of the Knee 2012 by myself, and as you can see here, comparison between different companies, and my technique on the second column here, and these are the differences between different technique. The technique we use called hospital-based PSI, and this is a patent, and also that paper is accepted in operative techniques, and it's going to be published soon. The steps actually for commercially available PSI are 5 steps. The imaging first with a CT scan or an MRI, and then the preoperative planning, manufacturing of the patient-specific templates, and then packing, sterilization, and then delivery to the hospital. So this takes about 4 to 6 weeks for implant companies to do this. And they outsource most of these steps. So some of the steps could be done like in Europe, others in America, and then they're going to be delivered to a hospital like in Asia. The hospital-based is that we do all these 5 steps under the control of the surgeon in the hospital or the premises around. This is basically what we do. As you can see here, the instrument that we use at the bottom here, and these are the PSI, rather than using more than 300 pieces of an instrumentation system. And you don't need to use intramedullary perforation, because with the planning, you look at mechanical access directly, rather than the conventional way where you look at anatomical and then you convert it to mechanical. We have this clever jig here for the femur, which has got 11 functions. Actually, we added 4 more functions to make it even suitable for using as a pin locator. And as you can see here, you can do everything, including the notch cut or the PS, if you have a PS knee. If you look at the literature review here, you can see that there are many studies and there are mixed results. There is one systemic review in Core 2015, and basically most of them, you say that there is no significant improvement with the using of PSI